Hello everyone, my name is Laura Zimmerman. I'm a nurse in the MSICU and I'm also the MSICU's Delirium champion. Today I'm going to talk about the assessment of delirium using the CAM-ICU and managing and preventing ICU delirium. Delirium defined is a disturbance of consciousness with inattention, usually accompanied by a change in cognition or perceptual disturbance that develops acutely and fluctuates over time. That being said, there are two cardinal things to that I just read. One is inattention. You must be inattentive to have delirium. Inattention is just the ability to concentrate on something or the ability to appropriately shift concentration to another item. The second part of delirium that you must have is that there must be an acute onset that fluctuates. So you must have these two things in order to be considered delirious. So causes of delirium are still being debated. The exact pathophysiology and etiology are debated, not really known or understood. However, researchers do believe that it's related to imbalances in neurotransmitters. These include serotonin, acetylcholine, GABA, and dopamine. And these neurotransmitters help control your cognitive function, your emotions, and mood. So there's a few different triggers, or actually not a few, I should say. There are many triggers and causes believed to attribute to this neurotransmitter imbalance. Basically, it's anything that can cause stress on the body, immobility, restraints, medications, that's a huge one, sleep deficiency or oversleeping, hypoxemia, dehydration, you name it, it can cause delirium in the ICU. There's, I think, about 100 different things that an ICU patient can be exposed to that will cause delirium. So there are three types of delirium. The first is hyperactive delirium or ICU psychosis, and this is what you kind of think of when you think of delirium. It's combativeness, restlessness, agitation. However, this only occurs in about 1% of delirium cases. This is frequently noted in people with alcohol withdrawal. The second type is hypoactive or quiet delirium, and this occurs in about 35% of ICU patients, and this is shown by patients being a little bit withdrawn, maybe a little quiet. It is harder to notice these patients or diagnose these patients. They just seem like they're a little bit down. The most common type of ICU delirium is mixed delirium, and that is a combination of both the hyperactive and the hypoactive. This occurs in about 64% of ICU patients. Again, it's a mix, so you might have periods of agitation and then a few hours later some somnolence, kind of fluctuates throughout the day, and that is the most common type that you'll see. There is something called rapidly reversible sedation-related delirium. That's a mouthful. It does represent about 12% of hypoactive delirium cases. And you'll notice this in patients who are currently on sedation. You'll go in, try to assess for delirium using the CAM-ICU. However, they'll be pretty lethargic, usually like a RASS of -3, -2. So you might try to do the CAM-ICU and they just fall back asleep. That is a CAM positive. However, within 2 hours, you should reevaluate 2 hours after their sedation has been turned off and do another CAM-ICU. And a lot of times, these patients will no longer be CAM-ICU positive. That, again, is the rapidly reversible sedation-related delirium. The prognosis is similar to patients who have never been CAM-ICU positive. However, if you do come across this, you should definitely chart it. It's something that should be followed up on, especially 2 hours after that sedation has been stopped. Another, it's not necessarily a real type of delirium, but it's something called subsyndromal delirium, and it occurs in patients who seem a little bit off. They might not be making much sense, might just seem kind of like they're getting delirious, However, when you go and do the CAM-ICU on them, they do not have that inattentiveness. This, again, is not a real delirium, but it's kind of a precursor to delirium. So if you notice this in your patients, you should be doing CAM-ICU a little bit more frequently on them, like every 4 to 6 hours. So common signs of delirium, which most of you know, is lethargy, decreased language perception. They don't seem to understand what it is you're saying. Disorientations, memory impairment, also inattention, hallucinations, delusions, emotional disturbances, agitation. However, it should be noted that a lot of times these symptoms they might be showing are so subtle you don't notice that at all. That's why you need to use the CAM-ICU to assess for delirium. So I know most of you know delirium is not a good thing, but I don't think many people really understand the significance it plays. So delirium, it attributes to longer hospital stay, longer mechanical ventilation, increased mortality, and that's not only while in the hospital, that's also a year out of the hospital after discharge. It also plays, obviously, greater long-term cognitive dysfunction, greater costs, and it can also attribute to something called post-intensive care syndrome, or PICS. And as noted in the slide here, 50 to 80% of mechanically ventilated patients, or 20 to 50% of non-intubated patients will develop delirium, which is significant. That's huge. So here's some pretty interesting statistics. Delirium more than doubles your risk for mortality while you're in the hospital, which is huge. For every day of delirium that you have in the hospital, it'll increase your hazard or your risk of dying by 10%. It also increases the cost of hospital stay by 39. Some people are saying even more, up to 50% of your hospital stay. And it has an estimated collective healthcare price tag of more than $143 billion just in the US. And again, there's more studies showing that this estimate might be low, it might be much higher. This is continuing on the statistics. So in patients who were delirious during their hospital stay, this includes just 1 day of delirium. A third of those patients mentally and physically stayed the same as the day they left the hospital. So this means that, you know, most times if you've been in the ICU, you're going to require rehab afterwards. This means these people stayed the same despite everything. They are not functioning at what they were in the past. A third of these patients will actually decline and get worse mentally and or physically, and only a third of those patients will improve, hopefully back to their baseline before coming into the hospital. This I found very interesting. At a 12-month follow-up, patients who were delirious during their stay, about 2/3 of them, 67%, had cognitive function scores similar to those with a moderate traumatic brain injury. So, I mean, it really is devastating. And about a third of those had a score as abnormal as someone with mild Alzheimer's. So it's definitely something not to be taken lightly. It's not something you go into the hospital and they get delirious and, oh, you know, they'll be delirious, so what? It really does affect them afterwards. Another thing found in about 2/3 of patients who were delirious in the hospital is that they'll develop this post-intensive care syndrome, or PICS, and that is something that will linger on with them probably the rest of their lives. So just to touch on this PICS, it's a disorder of new or worsening impairments in physical, cognitive, and or mental status, which arise from your critical care illness and interventions that persist beyond your acute care hospitalization. So it's found in about a quarter of patients who've been in the ICU who did not develop delirium, and about, as I mentioned before, 2/3 of previously delirious patients. These numbers, the 2/3, is similar to those who've been in war or rape victims, so it's quite a large number. And these symptoms include anything that can be found with PTSD, depression, suicidal ideation, suicide attempts, anxiety, grief, anger, and it can also affect your motor function as well. This they're finding is more and more common, and it's very, very unfortunate. We are part of a collaborative. It's an A through F collaborative. The A, B, C, D, E, F is a mnemonic of different delirium interventions, per se. We've been a part of this, and we've collected some data, and it showed that we have decreased the ICU stay by 2 days, and that's just starting. We're still getting this rolling. To go through each element, A is to assess and manage and prevent pain using a numerical scale, so like 0 through 10, or a CPOT, which is a critical care pain observation tool in patients who are nonverbal. So, and we make sure we treat pain first. That stands for the A. B is making sure that both a spontaneous awakening trial and spontaneous breathing trial have been completed, which our facility has been doing. We're almost at 100%. C stands for choice of sedation and analgesia. Sedation being trying to stay away from benzodiazepines and sticking more with propofol or dexmedetomidine. D is delirium, which we're going over here. So delirium assessment using CAM-ICU, managing and preventing delirium with various interventions, which I'll touch on later. E is early mobility, so getting your patients up and moving. And F is family involvement and empowerment, to make sure that they're involved with the patient's care as well. So now we're going to touch on the CAM-ICU, which is extremely important and will be the majority of the rest of this PowerPoint. So the CAM-ICU is a valid, reliable, and feasible method of assessing CAM or delirium in the ICU. Has about a 96% sensitivity, so that's quite high. It's actually the highest form of measuring delirium. It yields 3 results: positive, negative, and unable to assess. About 90% of CAM-ICUs take less than a minute. It's very, very quick. The other 10% will take no more than a couple minutes. And again, without appropriate use of this CAM-ICU, about 28% of delirium days will be noticed. The rest will not be identified. So it's quite important you're doing this, even on your patients who seem like they are not delirious. So RASS scoring, this is very important. As you know, RASS score stands for Richmond Agitation Sedation Scale, and that might be a misnomer, might be a little confusing. This is used on patients who have not even received sedation. It could be on patients who have, and also patients who have not. It's just measuring how either agitated, awake they are, or how lethargic or sedated they are. It ranges from a score of +4, which meaning you're extremely agitated, aggravated, down to a -5, which is comatose or paralyzed. We'll go through these in just a moment. So in order to assess this, when you go into a patient's room, you should look at the patient, see if their eyes are open, see if they're looking around, or if they make eye contact with you. If they do not, you should then proceed on to trying to elicit a response using verbal stimuli, so asking Mr. and Mrs. John Doe, open your eyes. If you do not elicit a response there, then you should go on to physically stimulating the patient to try to elicit a response. It's really important you don't just go in and touch the patient, because then you don't really have an idea of what level of sedation or how awake they are. So we'll go through briefly. I know this is kind of a repeater for a lot of you guys. Go through each. +4 is, again, very agitated, awake, combative. They're going to hurt you, just going completely wild in that room. +3 is when you're very agitated. You're purposely trying to either extubate yourself, pull on things, pretty agitated, but not attempting to hurt someone. +2 is just an agitated, so you might not purposely be pulling at something, but you're just kind of angry, just moving around. Positive one is more of an anxiety. So you're a little bit anxious, you might be tapping your foot or wiggling around, just not very comfortable. 0 is someone, you go into the room, they look comfortable, they're not wiggling around, they're just calm and kind of collected. A negative one, we see this quite frequently in the ICU on non-intubated patients, just might have had some pain medication, slightly drowsy. You're still making eye contact for greater than 10 seconds, but just not as, quick to respond. Negative 2 is light sedation, so you're going to briefly open and make contact or eye contact, but for no more than 10 seconds. So you'll look around, and then kind of nod back off. This is in most of our intubated patients when we're about to try to do an SBT on them. Negative 3 is a moderate sedation. So you're going to get a response to verbal stimuli. You're going to walk in the room, say so-and-so, open your eyes. They'll open them or they'll move, but they won't make eye contact with you. However, if you go into a patient's room, try to verbally elicit a response and nothing happens, you go and touch them, you sternal rub them, you could even suction them, and you do elicit a response. Again, no eye contact, but they might shrug their shoulder or move or open their eyes. Again, no eye contact. They're considered a RASS of negative 4. This is considered deep sedation. It is considered a comatose state. And again, we don't see this all that frequently in patients who've been in the ICU for a while. This might be someone right after surgery or maybe a couple hours after surgery, or someone who's being heavily sedated, like 4 and 400 of fentanyl and Versed. Negative 5 is unarousable, and this is obviously a comatose state. This is when you cannot elicit a response either verbally or physically. These patients are either snowed on like 600 of fentanyl and Versed, or maybe paralyzed, or unfortunately could be brain dead. No matter what you do, you cannot elicit any response. It should be noted that charting on the RASS should be done at least once an hour, and with changes, extreme fluctuations in RASS scoring. So say for instance your patient's like a negative 2, they're making some eye contact but pretty sleepy, and then all of a sudden they get really agitated, start thrashing, pulling at lines, trying to self-extubate. This should be documented in our charting system. Obviously deal with the patient first, deal with whatever's going on, and then go back and try to estimate to your best abilities when this occurred, and make sure you chart this. RASS, again, should be charted at least once an hour. So unable to assess is something that on our unit and other units, other ICUs, it has been noted people chart that a lot. However, the only time you should chart unable to assess is when your patient has a RASS of negative 4 or negative 5, meaning they're comatose. Again, negative 4, you can elicit a little bit of a response, but that's with like physical stimulus. And again, negative 5 is nothing. If they're a negative 3, if you can, get them to just move a little bit to verbal, then you can do the CAM-ICU on them. It's really important we note this. Again, this is a big issue on our unit. People charting unable to assess when really these patients can be assessed. If your patient's either too agitated or too sleepy to participate, then that means they have inattention, and therefore they're CAM-ICU positive. So alert and oriented patients, they can be delirious. Being alert and or oriented is not the same thing. It's not synonymous with being delirious. You can have someone who appears perfectly normal, talking to you. Again, you ask them what year it is, they know. However, they have this inattention when you do the CAM-ICU. So we should not be hearing, my patient's alert oriented, therefore they're CAM negative. That's not true. Unfortunately, you have to go on and do the CAM-ICU. So there are 4 features of CAM-ICU that you need to know. The first one is acute change or fluctuating mental status or mental course. The second is inattention. The third is your altered level of consciousness at this particular time. And then the fourth is a disorganized thinking. And the fourth element you don't necessarily have to go on to unless you meet a couple criteria. So most 90% of the time you're going to stop after feature 3. So feature 1 is acute change or fluctuating mental status. It's just a yes or no answer. So has this patient in the last 24 hours had a RASS other than 0? Or have they, has their mental status from baseline changed at all? If the answer is no to both of those, which is usually not the case in the ICU, then you are done. They've had no fluctuation, no changes, then they are CAM-ICU negative. However, I would again say like 99% of the time, patients have been getting analgesics. They might have a RASS of -1 for like even just 5 minutes. Then you're going to proceed on to feature 2. This again is just mentioning feature 1. So if they've had any changes in mental status over the last 24 hours, you proceed to feature 2. If not, then you're CAM negative. So feature 2 is inattention, and as I mentioned at the beginning of the presentation, you have to have inattention to be delirious. So to test this, it's pretty simple. You ask the patient to squeeze your hands, and every time you say the letter A, you want them to squeeze your hand. You can say a series of letters, it doesn't really matter as long as you have 4 A's in that 10-letter sequence. So you can say abba dabba day, save a heart, but hearts but with 2 A's. Anything that your heart desires, but you just have to have 10 letters in total and 4 A's. Again, if they can't squeeze your hand, you get creative. There's other ways. You can ask them to blink, to nod, to wiggle their toe, as long as they can do something repetitively. If they have 0 to 2 errors, then they are considered CAM-ICU negative. However, if they have greater than 2 errors, then you have to proceed to feature 3. So feature 3 is quite easy. It's just altered level of consciousness. So you're just looking at what their RASS is right at this time. So we went through that. So again, RASS +4 to -5. If it's anything other than 0, then they're considered CAM-ICU positive. If they had the inattention and have a RASS of 0, you have to proceed on to feature 4 of the CAM-ICU, which is disorganized thinking. So again, most times this person's not going to have a RASS of 0, but occasionally they do. Feature 4 is actually 2 parts, and it's testing your disorganized thinking. The first part is disorganized thinking questions. So they're just 4 yes or no questions you're going to ask. And then the second part is a command that they have to complete in entirety to, I guess, per se, get a point. There are 5 points in total. If they have more than 1 error, then they are considered CAM-ICU positive. Approved questions include, will a stone float in water? Are there fish in the sea? Does 1 pound weigh more than 2 pounds? Or can you use a hammer to pound in a nail? There's a couple others on the next page I'll show you. For the command portion, what you're going to do is you're going to do this, and you're going to ask the patient to hold up this many fingers. You don't want to say, hold up 2 fingers or whatnot. You just want to demonstrate, just say, hold up this many fingers. You should watch them do that, and if they do that, then say, now do the same thing with the other hand, and then they should demonstrate that. Again, you shouldn't demonstrate that to them. You should let them just do that using your verbal command. If they have physical limitation on one side, you can say, instead of saying, hold up, or now do the same thing on the other hand, you can ask them to add 1 more finger to it. So they'll go from 2 fingers to 3 fingers. If your patient has no, or has complete physical limitation or no movement, motor function on their hands, or is blind, you actually don't need to go on to the command portion. You'll score them solely off the disorganized thinking questions. This being said, if they get more than 1 error, meaning they miss 2, either 2 questions, 1 question, 1 the command, then they're considered CAM positive. If you're going through the 4 questions and they get 3 of them right off the bat wrong, you don't even have to go into the command because it's obvious they've already missed 2 or 3 points. Again, if they get greater than 1 incorrect, then they're CAM-ICU positive. These are the 4 other questions that I mentioned. Have also been approved. Will a leaf float on water? Are there elephants in the sea? Although I might change that to, do elephants live in the sea? Do 2 pounds weigh more than 1? Or can you use a hammer to cut wood? So this was mentioned before. If you're doing the CAM-ICU in patients who are physically limited, you can be creative. You can ask them to blink during the Save a Heart or the feature 2. You can ask them to wiggle their toe or to just move their arm. Whatever they can do repeatedly, you can ask them to do. You should never chart unable to assess if they're physically limited. There's ways around that. This is a little bit more tricky. So CAM-ICU in patients with neurological conditions, either dementia or stroke or a traumatic brain injury, you can accurately assess CAM-ICU if you have an understanding of what their baseline is. In these patients, hopefully you'll talk to a family member or a physician that knows them well, like maybe from spinal cord or from any other multidisciplinary team. You just want to have an idea of how they normally are if they're functioning at baseline. If a family member or a friend is present and they're very familiar with the patient, you can ask them, is this normally how they've been? Has anything changed? You can go on and perform the CAM-ICU on these patients and kind of see how they do. And then if there's a family member nearby, you could say, normally can they perform that? And normally can they follow these commands and squeeze appropriately? If they say no, they normally can't, this is their baseline, then they're CAM-ICU negative. There's no additional delirium on top of their neurological problems. However, if you do not have a baseline, you're not really sure what they are usually, you can go ahead and do the CAM-ICU. You might find that they are CAM-ICU positive. This doesn't necessarily mean they're delirious, but you will still chart they're positive and mention to the physician or nurse practitioner that they are showing signs of delirium, but whether or not it actually is delirium, you leave that up to the nurse practitioner or physician to decide. So the frequency of CAM kind of varies. It should be done every 8 to 12 hours on patients who've had consecutive CAM-ICU negative scores. However, if they do have a positive score, then it should be done about every 4 to 6 hours until they've been CAM-ICU negative for about 24 hours. You should also do it, as mentioned before, 2 hours after stopping all sedatives and after extubation. Just sometimes the sedatives need a little bit of time to get out of the system, so that should be done as well. Again, PRN or with any type of mental status change, you should obviously do CAM-ICU just to see if they've become delirious. And although this should be noted, although a patient may be CAM-ICU negative, if they've had CAM-ICU positive scores in the last 24 hours, they are still considered delirious. They are no longer considered delirious after a full 24 hours of consecutive CAM-ICU negative scoring. It should be noted, it should not be done every hour. I have noticed that in the past. You should not be charting CAM-ICU every hour, nor should you be doing it, or you will make your patients delirious by waking them up that often. For documentation, again, there's only 3 different types. There's a positive, there's a negative, and there's an unable to assess. Again, unable to assess should only be done when they're in a comatose state of -4 or -5 RASS. Obviously, if they're negative, you chart negative. If they are positive, you need to kind of document what feature they're positive in. So it's either going to be feature 3 positive, meaning that they had the inattention, they weren't able to squeeze, and their RASS was anything other than a 0. So it was a positive or it was a negative. Or you say they're CAM-ICU positive, stage 4, meaning that you had to go through onto the disorganized thinking questions and they didn't get those right. So it's nice to establish what they were positive in. So preventing and reducing ICU delirium in the ICU there's a few things. Treating pain first. So if a patient is agitated, you should probably go ahead and treat them with a pain medication rather than a antipsychotic, because usually agitation is brought upon by pain, and maybe it's just pain that hasn't gone noticed, hasn't been treated well, so treat pain first. The second is to promote consciousness. You want to ensure your patient is awake during the day, not heavily sedated if they don't need to be, and up and moving. Another is weaning mechanical ventilation. As mentioned before, patients should all have spontaneous breathing trials when it's appropriate, when it's safe, and spontaneous awakening trials, meaning you get off sedation. The fourth is increased mobility. This is huge. As mentioned before, this is the most effective and only proven way to reduce the duration of delirium. So it's really important that on day 1 you start mobilizing your patients or attempting to if it's safe. Another thing that's really important and shown great improvement on reducing incidence of delirium is increasing your patient and family participation, including them in rounds, informing them what's going on, letting them help out, if you're ambulating or moving the patient. It's important that they're involved. And by doing these things, you can reduce complications associated with delirium, you can reduce delirium and improve patient outcomes. So non-pharmacological delirium management strategies, there are a number of them, and these should all be tried first rather than just trying to give a medication. So it's really important you start out mobilizing your patient early. Everyone should be mobilized on day 1. Even if they are paralyzed, it's been proven that passive range of motion can actually reduce the incidence of delirium. So that's quite important. Mechanically ventilated patients are not excluded from early mobility. When it's safe and appropriate, you can ambulate these orally intubated or trached patients. And again, as I mentioned, early mobility has been shown to reduce the duration of delirium by half, which is huge. It's the most effective intervention in delirium management. Sleep hygiene and sleep enhancement is also extremely important. Making sure that their daytime and nighttime hours are normalized, so trying to keep them awake during the day, try to keep them engaged, out of bed to a chair with the lights on, maybe let them look outside, and at night trying to reduce interruptions, letting them sleep, reducing noise in the ICU, that can help. You can give them earplugs, eye masks. You could try to talk to other members of the team, respiratory therapists, physicians, about clustering care. If you're going to have to interrupt and wake up a patient in the middle of the night, try to do it at once. That will help as well. And it should be noted that nighttime sedation, so putting someone on like Dex or Versed or something overnight to let them sleep, is not the same as sleeping, and that doesn't really count as nighttime normalization. So to continue on with some more non-pharmacological management of delirium, there's frequent reorientation. Make sure that you're reorienting them, saying who, what happened, where are you, why are you here, and then how did you get here. It's important to make sure that a clock is nearby so that a patient can at least keep track of time. Just let them know if it's daytime or nighttime. It's also important to use their sensory assistive devices like glasses or hearing aids, dentures, that can all help. As mentioned before, SAT, SBT should be performed daily when it's safe on patients. Pain should be managed first by assessing pain hourly and making sure that you treat pain first rather than agitation. Another huge thing is eliminating unnecessary medications. Almost any medication can be attributed to delirium. Some are a little bit more deliriogenic than others, like benzodiazepines are notorious for causing delirium. So you want to try to avoid those medications altogether. Also discontinuing all unnecessary lines, central lines, restraints, Foleys, all of that causes stress on the body and can lead to delirium. So if they're unnecessary, those should be discontinued. This is kind of a mnemonic to think about prior to starting meds. So you want to think about reducing toxic situations, so reversible or aggressive treatment of if you're dehydrated, or CHF, shock. H stands for hypoxemia, so if they need a little more oxygen, give them a little more oxygen. It also has been noted in some documents as haloperidol, but you want to think about that before giving that right away, because there might be other interventions you can do first. I is trying to see if there's an infection going on, or if you need to mobilize this patient, maybe they've been immobile for too long. N is the non-pharmacological interventions, which we just talked about, eyeglasses, sleep-wake cycle. And K is electrolyte disturbances. So moving on to pharmacological management. So I should note that there has been no proven medication to help with delirium. Nothing's been proven. Things have been studied. However, they need more research on these. The evidence is definitely lacking. Usually, when it comes to this, less medication is more. Atypical antipsychotics may reduce the incidence or duration of delirium in these patients. Again, it's not 100% sure. They're still doing more research on it, but if you're going to give an antipsychotic because of agitation, try to use one of these atypical antipsychotics. That includes quetiapine or Seroquel, which is really good, olanzapine or Zyprexa, which is another one usually given at night to help people sleep as well, or risperidone. However, these three agents are only available in oral form, except for risperidone can be an IM form. So it's a little bit difficult, and that may eliminate the use in a lot of patients. Haldol has been used and can work, but there still might be a tie with Haldol and delirium. So you want to make sure that agitation is not from untreated pain. Again, I know I've been hounding you on this. Treat pain first. Then if after treating the pain and everything, they're still agitated, then go ahead and give one of these atypical antipsychotics or Haldol. You also want to make sure that you're measuring these patients' QTC frequently, because as all these atypical antipsychotics can cause QTC prolongation. And you should make sure that within 48 hours of a delirium resolution that these medications are stopped. So they should be off their patient's charts within 48 hours. So again, I mentioned benzodiazepines are deliriogenic. You should try to completely eliminate, if not reduce as much as possible, the use of these. You should eliminate any type of unnecessary medications. That includes antibiotics and steroids. Reglan is also a very deliriogenic medication. There's been direct ties to the use of that. So try to eliminate that as well. And the ICU team, when they do their rounds, should kind of go over and do a med reconciliation to see if all of these medications are needed. These are just two graphs showing, well, I'll just start with the first one. This SEDCOM trial is showing delirious patients using benzodiazepines and dexmedetomidine. Dexmedetomidine is in blue, and the midazolam or Versed is in red. So starting, the patients are all delirious. However, as you see with the use of dexmedetomidine for their sedation, their delirium decreases, whereas with the use of Versed, it stays pretty high. So it's just showing how deliriogenic that is. With the second graph here, this is the probability of transitioning to delirium with the use of lorazepam or Ativan. So this is the dosage, the milligrams. So your probability, so you start off almost at 0. It goes to like 90% after you've used about 40 milligrams of Ativan. So that's showing that if you're giving them a hefty dose of a benzodiazepine, then your chances of becoming delirious are quite high. This is just medication-related delirium or strategies to reduce delirium. It's just for your toolkit. I have it in your packet for you, so you can look through that. It's everything we have gone over. This decision tree for the delirium protocol was taken with permission from Vanderbilt University and Hospital. And it's basically everything that we've gone over in this PowerPoint about different non-pharmacological interventions for delirium and delirium prevention, SAT, SVT. It's available in your packet as a tool for you to use. And to close out this presentation, I just want to leave you with a quote from a patient who was delirious, spent some time in the hospital. They, I think, very eloquently paint a picture of what delirium feels like. The time I spent seems like I was in a huge, empty, gray space, sort of like a monster's underground parking garage with no cars, only me, floating or seeming to float on something. Every once in a while, I would get to the edge of something horrible, and I thought, if I just let go, then this horror will be over. Just want to leave that with you. It's a very poignant statement. Just to let you know that delirium is not inevitable. There's things we can do to prevent it. There's things we can do to help decrease the duration of it and to catch it early. It's a huge deal, and I think it needs to be treated as such. So thank you for your time, and thank you for listening.